that make sense? Okay. Now, knees will be bent the entire exam. For now, for the camera, I'm going to lower them just so we can see, okay? All right. So there's going to be three parts to our inspection, okay? 3 general parts. First, we're going to do our general inspection. That's the surface. So just like we've done in other parts of the body, looking for masses, rashes, lesions, scars, right? Same things. So that's surface, general inspection, right? Then we're going to look for contour. The 3 contours we want to look for are flat, that's normal, protuberance or distension, which means it's rounded, and then scaphoid, which means it's sunken in, right? So general inspection, the surface, then contours. Finally, we're going to look for movement, and particularly peristalsis and any pulsations, okay? So we start with general inspection. Patient, go ahead and raise up so you can see the abdomen. We start to look at the abdomen, right? Rashes, the same rashes we saw on the chest could be on the abdomen, all right? So we're not going to rehash those right now. Masses, what kind of masses might we see? Could we hernia? What's that? So shingles would be a rash we might see. It would wrap around dermatomal. What is the lesion with shingles? Fluid filled vesicles, right? Less than a centimeter. Good. What did you say? You said a hernia? Good. Hernias. Now, we talked in lecture. What does herniation mean? So in the abdomen, it means bowels come through the abdominal wall, right? Intestines through the abdominal wall, right? If I had a hiatal hernia, that's not intestines through the abdominal wall. What's that? Stomach through the diaphragm, usually through the lower esophageal sphincter, right? So hernia means that some body tissue has pushed through the cavity that's supposed to contain it. Does that make sense? When we talk ventral abdominal, it's the intestine pushing through the abdominal wall. Where do these occur? So umbilical is a common place. Everyone seen an umbilical hernia? People call them an outie. It's intestines that push through the abdominal wall. It's intestine right under the skin. Do you know that? That's what's going on. So umbilical, where else can you get hernias in the abdomen? So inguinal, right? So we're going to talk specifically inguinal next week when we get to pelvis. But so inguinal canal, right? In a male, the testes descends through the inguinal canal. There's an opening, and intestines can push its way through there and herniate into the pelvis, right? Good. Where else? Have you seen any others? What just in general, where do hernias in the abdomen occur? What do those things have in common? Not midline, but they occur at weak spots. Okay? So the intestine's not going to push through the rectus abdominis muscle, right? But inguinal canal is a canal. That's a weak spot, right? Femoral canal, there's an empty space. That's a weak spot. The umbilicus, there was a tube there. We cut it. That's a weak spot. If you've had surgery, that scar is never as strong as the original tissue. Weak spot, incisional hernias. The other place, aponeurosis, are weak spots, right? So it may not go through the muscle, but the linea alba, right, midline, does that make sense? Linea semilunaris are weak spots where the abdominal viscera can push through the wall. Does that make sense? So it occurs in weak spots. So as we look in the abdomen, you're thinking linea alba, linea semilunaris. If there's a incision, it could be there, umbilical. Does that make sense? That's where we find them. Now, these are important. What did I tell you are the 2 most common causes of small bowel obstruction? You can tell me. We're talking about one. So one's a hernia, and the other was adhesions, right? Abdominal adhesions, most commonly from surgery. So 10% of individuals that have abdominal surgery will develop obstruction because of the scar tissue that forms, the adhesions. Okay? And then in the large bowel, we said diverticulitis and tumors, masses, are the most common cause, right? So as we look, if we see hernias, I mean, it's important now, because, well, particularly if they become painful, they can strangulate, right? It can cause obstruction. We said when they come through the abdominal wall, it's a common way for obstruction to be caused, and that can be very serious, right? If peritonitis sets in. So that's important. If we see incisions, right, it's important to know their history, but it's also important to know that there's likely scar tissue underneath there, right? And 10% of them will have obstruction because of that scar tissue. Does that make sense? So we need to keep these things in mind when we look at someone. If someone comes in and they have signs and symptoms of obstruction, and they've had a couple of abdominal surgeries, that needs to be top of mind. Does that make sense? All right, so we're looking there. Now, we talked about in lecture, not today, but earlier this week, all these vessels we could see dilated. And you guys all told me that was called caput medusa. All right, good. Now, when we see these vessels, portal hypertension can cause it, and then inferior vena cava obstruction can cause something that looks very similar. And we differentiate by determining, if we put a line right here through the umbilicus, right, differentiating which way is blood flowing on the superior portion of, superior to the umbilicus and inferior. Does that make sense? Now, you do it above and below because that's just standard of care. Really, what's going to differentiate is how the blood's flowing inferior, right? So you kind of roll down your belt line just a bit. That's good. That's good. So what we'll do is we're going to find a vein. If we had dilated veins here, a vertical vein. Does that make sense? We want one that's a couple inches long without a bunch of branches because we don't want blood moving out any other way, okay? What I'm going to do is I would press down in the middle of it, and then I'm going to pull my fingers apart. You see that? Now what does that do to the blood? You see how I'm pushing it out from between my fingers? So we have an area in between my fingers where the blood has been pushed out, right? So then I may remove this inferior finger, right? If blood is flowing towards the head, what's going to happen through that vessel when I remove it? It fills with blood, right? However, if blood's flowing towards his feet and I remove, what happens? Nothing. It stays empty. And we could do the same thing with the top finger. Does that make sense? So we determine which way blood's flowing. Now, superior to the umbilicus towards the head, inferior to the umbilicus towards the head, tells us there's obstruction in the inferior vena cava. It's heading up through collaterals. If it's superior above the umbilicus but inferior below, then we know the cause is portal hypertension. Is that clear? Make sense? Okay, so we do our general inspection. Those are things we're looking for, right? Then we want to look at the contour. Is it flat? That's normal. Scaphoid sunken in. We worry about malnutrition, maybe anorexia, those type of things. Or protuberance. Is it distended? What were the 7 F's of protuberance? Flatulence is one. What's that? Fat. Fetus. Feces. Fluid. Fibroid. Fatal growth. So fat, flatulence, feces, fetus, fluid, fibroid, fatal growth. So fat means they're overweight, right? The protuberance is adipose tissue. Flatulence, they're distended, they're bloated. Maybe if they had obstruction, they start to bloat. Does that make sense? What's it mean, fetus? The patient's pregnant, right? Where would that protuberance be in the abdomen? Lower in the abdomen, right? Good. What's the fluid refer to? What do we call the fluid in the abdominal cavity? Ascites, right? Good. And then the fibroids are benign growths, and then fatal growths would be malignant tumors. Does that make sense? So those are all things we need to look at as to why there's protuberance. And then finally, we want to look for pulsations, right? So this is my patient. We're going to look for movement. Peristalsis is what? What is peristalsis? Yeah, it's smooth muscle contraction that moves bolus through the intestine, right? Should I see that on my patients, typically? No, unless they're really thin. If I do see it, what's likely going on? There's hyperactivity of the bowel. What's that? Could be early obstruction. Early obstruction, the bowel will push hard trying to clear whatever's obstructed it, right? Diarrhea. You get increased peristalsis. That makes sense? So you may see increase, but that's rare. You typically won't see that in somebody. The other thing we want to look for movement-wise is pulsations of the abdominal aorta, okay? So the abdominal aorta is running in the abdomen from where to where? Where would we see it in the abdomen? What's that? So xiphoid to umbilicus, right? And it's just lateral to midline, okay? What happens at the umbilicus? Why do I say it's not going past the umbilicus? It bifurcates, right? What's it bifurcate into? The iliacs, right? So this is where we would see the abdominal aorta, right? So we look for a pulsation in here. You may see it, you may not. It's normal to see it, okay? What we want to know is it really bounding? Is it larger than it should be, okay? So if he takes a deep breath for him, let it all out, and hold it out. So that's usually what I'll do, and I'll just look in here to see if I can see the pulsation. Does that make sense? Okay, relax for me. Good. So what are the three broad categories of inspection? Surface, contour, movement. Go ahead and pair up and look for those in your patient, okay?